Hello, everybody. My name is Metin Gülmezoğlu. I'm the Executive Director of Concept Foundation, and welcome to this second webinar on accelerating innovation for mothers. And this particular webinar is focusing on breaking the gender bias and how gender biases and other concerns impact on pregnant women and lactating women's participation in clinical trials. This is the second one, and we are deliberately organizing this 2 days before the International Women's Day to celebrate International Women's Day a little bit in advance. And in this webinar, we are going to be recording the webinar, so those who may not be able to stay for the whole length of the webinar can see and hear from our recording. And unfortunately, we are unable to operationalize French subtitles, but you are welcome to put your questions in French, and we will try to respond to those questions during the course of the 60-minute webinar. So without further ado, I want to introduce our moderator, and she's Professor Megan Boren. She's an associate professor at University of Melbourne, and she's the principal investigator of the AIM Gender Research Project. Concept Foundation and University of Melbourne are implementing with support from MSD for Mothers in Nigeria and in India. So Megan, over to you. Thank you.
Great. Thank you so much, Metin, for the introduction, and warm welcome to everyone who's joining us here today for this webinar. We're really delighted to be able to share with you some of our work about how we can collaborate to optimize the participation of pregnant women in clinical trials, as some of the work that we've been doing to unpack in the AIM Gender project. So just as a quick overview for today's session, we're going to start with a broad overview of the AIM Gender project, what our aims are, and what we are hoping to achieve in it. We'll have that overview for about 10 minutes. And following that, we will have a panel session with 3 key experts working across the areas of gender equity, clinical ethics, and maternal health. And we'll be discussing with this panel some of the key barriers, progress, and the role of different types of stakeholders in forging a path forward to gender equity in research and development. So first up, it's my honor to introduce Dr. Mridula Shankar. So Mridula will be giving us the overview of the AIM Gender project. She's a postdoctoral research fellow in sexual and reproductive health and rights at the University of Melbourne here in Australia. She has a particular interest in improving understanding of reproductive health behaviors and outcomes using innovative approaches to measurement and study design. Over to you, Mridula.
Thank you, Megan. Next slide, please. Thank you. So over the next 10 minutes or so, I'm going to provide an overview of the work of the AIM Gender Study on factors influencing the participation of pregnant women in clinical trials. Next, please. So for many women around the world, pregnancy is a time of joy, but it can also be a time of confusion and fear. Whether it is a common cold or something potentially more concerning like preeclampsia, women are faced with uncertainty and sometimes confusing advice on treatments and medications. Our lack of knowledge in the field about therapeutics for pregnant women is linked directly to the historical and ongoing exclusion from clinical trials for vaccines and medications, primarily due to a singular focus on the potential for fetal harm. These long-standing patterns of exclusion have resulted in large evidence gaps and contributed to limited development of fit-for-purpose diagnostics and novel therapeutics for women during pregnancy. Next, please. So at the AIM Gender Project, we have taken a gender lens to the issue and identified 4 critical roadblocks that must be overcome to better represent pregnant women's interests in the global biomedical research agenda. First is the indoctrination of pregnant women as a vulnerable group in need of protection from biomedical research. The historical calamities of thalidomide and diethylstilbestrol are cautionary tales about the consequences of marketing untested drugs to pregnant populations. The human cost of these tragic events underscore the importance of undertaking preclinical studies and including pregnant women in early phase clinical trials, with appropriate safeguards to minimize the potential for harm. Instead, notion of pregnant women's vulnerability has gotten codified into regulations, which have long served to justify their systematic exclusion from research. Such a protectionist approach has implied that the ethical and practical complexities of drug research in pregnancy is too difficult to warrant investment and innovation. Second is the critical knowledge gaps that have been sustained due to the way research has been conducted in a gender-biased manner. Pregnancy is a very unique physiological and immunological state where the body undergoes substantial changes to support fetal development. These adaptations have important implications for how medications are absorbed, distributed, and excreted, affecting its actions on the body. However, we do not have a systematic approach to collect this data, and instead often rely on data obtained from accidental exposures to drugs or vaccines, as was recently the case during the COVID-19 pandemic, or to off-label use in the post-marketing phase. This puts pregnant women in very precarious therapeutic positions and paradoxically shifts the responsibility for therapeutic drug use from closely monitored clinical trials to off-label use in everyday clinical care, leaving millions of pregnant women and their healthcare providers to make therapeutic decisions on their own with incomplete or non-existent efficacy and safety data. Next. The third big roadblock is the double disadvantage of women who live in the Global South. Pregnant women in the Global South experience an intersectional double disadvantage because, in spite of experiencing a disproportionately high risk of maternal mortality, their gender and country of residence contribute to reduced agency and opportunity to participate in clinical research. While there's a growing number of trials in low and middle income countries, trial focal areas are often not representative of the epidemiological burden of maternal disease. Next, please. Biomedical research has also historically undervalued the expertise of lived experience, including in maternal health, where only a minority of trials are informed by the perspectives of people targeted by the intervention. Despite the potential for rich insights into what works, what doesn't, and why, through formative qualitative research and process evaluations, these methods are not consistently integrated into trial protocols. Next slide, please. So the AIM Gender Project aims to address several existing knowledge gaps on this issue. In a systematic review that I will briefly discuss now, we have synthesized the facilitators and barriers to engaging pregnant women across all levels of the clinical research ecosystem and across multiple stakeholders. Through ongoing qualitative research, we seek to understand how women, their families, healthcare providers, and ethics committee members view and understand biomedical research in relation to pregnant women's health interests. And across all of our work, we apply a gender lens to understand how gender relations of power influence access to resources, social norms, and the rules and decisions associated with participation. Next slide, please. So in our recently concluded systematic review of factors affecting the participation of pregnant women in vaccine and therapeutic clinical trials, we synthesized data from 56 primary research records and 27 countries into 5 overarching themes and 24 review findings. I'll now present a short subset of these findings across the themes. Next, please. We found that women have a limited appetite or high perception of risk during pregnancy. Women discussed weighing the risk of their medical condition and its impact, especially on the baby, against risks of the intervention and its potential benefits. Women were less likely to participate if they felt healthy or perceived themselves at low risk of experiencing or being negatively affected by the condition, if they believed that they had nothing to gain from participating or felt concerned that the intervention risks were too high. Pregnant women were also more likely to participate when they perceived that participation could give them access to higher quality clinical care or access to vaccines or therapeutic products that had previously been denied or were not accessible outside of the context of a trial. Next. Importantly, women's willingness to participate in trials was greatly influenced by trust, confidence, and faith in medicine and research, and women often relied on the opinions of healthcare workers that they consulted with regarding the efficacy and safety of the intervention. For some women, a lack of understanding of the differences between research and regular clinical care, when combined with therapeutic hope, led to therapeutic misconceptions and unmet expectations about the personal benefits from trial participation. This ethical dilemma was also recognized by study investigators and ethics committee members, particularly in the context of the dual roles played by clinician researchers. Next, please. Some women, healthcare workers, ethics committee members, and regulators perceived that pregnant women might not be able to make decisions by themselves about trial participation due to the involvement of the fetus, the inability to make rational choices during pregnancy, the stressful context of hospitalization, particularly at the time of childbirth or during complications, and financial inducements. However, research staff and some women believed in the right to bodily autonomy to make decisions by themselves. Women viewed other people making decisions regarding their participation on their behalf as a violation of this right, though some women declined participation due to pressure from family members. Next, please. While some regulators, ethics committee members, and study investigators strongly supported inclusion of pregnant women in clinical trials, most stakeholders start from a presumption of minimal risk to the fetus. This results in women's exclusions, especially in the context of poor public stewardship, ambiguous guidelines, insufficient data on intervention safety, and the complexities and subjectivities in risk assessment, poor agreement on appropriate trial design, time-consuming ethical processes, and concerns about reputation. Next slide, please. So in addition to the systematic review, the AIM Gender Project is also collaborating with research partners in India and Nigeria to better understand the preferences and perspectives of stakeholders at the intersection of communities and the health system. We're doing this through qualitative research with pregnant women, their family members, healthcare providers, and ethics committee members. And our choice of locations is also informed by the fact that India and Nigeria together account for 37% of global maternal deaths. And research investments in these countries are critical to enhance maternal and infant survival. This work is ongoing, and we hope to share findings later this year. Next slide, please. So I'd like to finish by acknowledging our collaborators on this project. And Megan, back to you now. Thank you.
Great. Thank you so much, Mridula, for that lovely overview of the AIM Gender Project, and really excited to be sharing those results with you soon. So our systematic review will hopefully be published in the next few weeks, fingers crossed, and more results from the qualitative work in Nigeria and India coming later this year and into early next year. So thank you so much for that. We'll now be switching over into the panel discussion, and excited to share the floor today with three experts working in this space. The first is Dr. Claire Delaney. So Claire Delaney has over 15 years of experience as a clinical ethicist and is currently the chair of the Central Human Ethics Subcommittee at the University of Melbourne. So Claire will be bringing a really important bioethics lens to our discussion today. We also have with us Dr. Anna Coates. Anna is a gender equality, intersectionality, and health equity expert who is currently the senior gender technical lead and unit head at the World Health Organization in Geneva. So Anna will be sharing a really important sort of gender equity lens to this work and how we conceptualize this more broadly across the sexual reproductive health and rights spectrum. And then lastly, we have joining us Professor Yoshida Puhar. Yoshida is the head of obstetrics and gynecology at the Jawaharlal Nehru Medical College in Belagavi, India. And Yoshida has been the principal investigator for many World Health Organization clinical trials, and has also been one of our collaborators on our AIM Gender project. So welcome to the panel. If you could please turn on your cameras and microphones, we can get kicked off. Great. So for this part of the panel, we do have a few questions that we'd like to pose to the panelists. And if you have other questions that you'd like to put in the chat, please do so. And we will be moderating the chat and pose questions to the panel as possible. Okay, so starting off with Anna. As we heard from Mridula's overview of the AIM Gender Project, there's growing acknowledgement of the harms of excluding pregnant and lactating women and people from clinical trial research. And as we know, this is of course happening in a long history of gender bias in research. Could you tell us a bit about what are some of the roots of this gender bias and what are the impacts in terms of perpetuating health inequity and gender inequalities?
Yeah, thank you, Megan, and thank you for the invitation to participate in this panel, and congratulations on the really important research that's being conducted as well. You're quite right, there is a bias in the research ecosystem, and there is a bias. Clearly, that is a result of broader gender inequalities in our systems. Health systems are not an exception to that. Neither are health information systems nor research ecosystems. The Beijing Platform for Action was adopted in 1995. It's the most comprehensive global policy framework for gender equality, and it has urged the need for more research and data on women's health since then, but we still have a very long way to go, as we've just heard. The male body is still the norm in most clinical research, and for many, that's simply not even questioned or seen as a problem. And I think there are many reasons for that. One reason is the silos between biomedical and social science fields of inquiry. Social science fields of inquiry are the ones that have often been highlighting gender inequalities more broadly, and they don't necessarily always talk to one another. It's also historically the ways in which our research methodologies and systems have been set up based on a male norm, and the structures and power that still exist which uphold that. And that unfortunately means that there have been insufficient will and interest often to change that system. There's a lack of female leadership in science, which is, doesn't necessarily lead to that, but could help have more attention to what the specific needs of women are, including pregnant and lactating women. There's also truth in the saying that we measure what we value. Health, more than any other, is an evidence-informed field. By women's health in all its dimensions not being prioritized in research, the specific needs of women and health, women and girls and health, are not prioritized in the health system. And that also feeds into furthering inequalities, because it leads to women's health being very narrowly conceptualized, particularly in terms of their reproductive capacity, but even in that sense being poorly understood and under prioritized. And we have to acknowledge, as I think we've already really heard through the really great presentation, that this is an extension of some often very politicized concepts about women and their bodies, and whether women's health is first and foremost about women's needs only, or whether it's about their reproductive capacity. But when we don't prioritize all women's needs, as women's needs in themselves and as rights, it effectively means that achieving the best possible health outcomes for all is undermined. And more importantly, it means that 50% of the population are really not able to fully exercise their right to health without discrimination, to exercise agency, and as we've just heard, bodily autonomy, and to take informed evidence-based decisions about their health. So it is also a rights issue as well.
That's great. Thank you so much, Anna. That's a really great overview of some of the wicked problems I think that we're facing in this space. Yes, and I agree with that eye roll completely. I think something that you touched on early too really spoke to me. I'm a social scientist, and one of the things that really excited me about working on the AIM Gender Project was really bringing the sort of long history of social sciences and addressing some of these wicked problems in gender equity and social justice into this sort of research and development space. And I think this is sort of one of the powers that we have as our partnership together with the Concept Foundation. So thank you so much for that. Yoshida, if you could turn your camera on, if that if that's possible, microphone, we'd love for you to join as well. And question for you, Yoshida, are there areas where progress has been made so far about more equitable inclusion of pregnant women in clinical trials? If so, what are these areas and what has sort of contributed to these positive changes?
Hi, Megan. First of all, can you hear me?
Yes, we hear you. Great.
Thank you so much for having included me in the panel. Yes, definitely there are areas where progress have been made. We could look at it at the institutional level, at the community level, and at the participant level itself. So at this institutional level, stringent screening of protocols for participant safety, because that is the main thing. Like whenever a pregnant woman is enrolled in a trial, the first question that is asked by everybody, she, her family members, the husband, the healthcare provider, is about the safety. Second thing is monitoring. Monitoring has become more stringent, and quality training, recurrent quality training, and maintaining a long standing health relationship with the public healthcare system as well as the participant. Now, example for at JNMC, we've had a long-standing relationship of more than 30 years. We are associated with various peripheral health centers in and around Belgaum and even in the surrounding districts. And then providing additional care and services to the pregnant women. We have had many instances where we've gone beyond our way to help women who were a part of the trial. Though they've completed the study, if there were any problems, we have taken care of it. And then coming to the community level, maintaining or creating a rapport with the village leaders, creating community sensitization of all the health problems and the requirement of research, and also building of the rapport of the institute. What has happened currently is we in KLE, we've built a very good rapport in and around Belgaum because we've spoken to them. We've had good outcomes. We've shared the good outcomes with them. So building up of a rapport is also very important. And finally, at the participant level, giving her safety, that's the main, like ensuring safety to the patient and also giving care to her and her family members. Definitely, it has helped us to break for a positive change. So the main factors enabling for a positive change are our long-standing relationship with the healthcare system, the participant and the healthcare provider, ensuring safety of the participant. As I told you, even if she's out of the trial, we need to go beyond and ensure that once a woman is in the trial, we need to look into safety of her, creating sensitization among all the community stakeholders. That is very important. And dissemination of the findings. Dissemination of the findings among all the stakeholders has definitely made a progress, and reflections of the study findings in the form of implementation. That is nothing but translation of evidence into practice. Say, for example, our carbotocin trial, which was conducted, once the results came in, the WHO guidelines were updated. Then we held multiple meetings. We covered this at all conferences, at all CMEs. We gave guest lectures. We talked to the Ministry of Health and Family Welfare. And now it is being implemented into the national guidelines as well. So I think these are the areas where progress have been made, and these are the factors which we could definitely make. If we improvise on them, probably in future, again, we could do better.
That's great. Thank you so much, Yoshida. And I think we do have so much to learn from your team in Belgaum. So the Yoshida's team has led some of the biggest and most influential maternal health trials that have been conducted anywhere in the world. And I think something that is really important, or a few things that are really important that you just mentioned, Yoshida, is really that rapport with community and making sure that you're really engaging proactively and on an ongoing basis, not just in the context of one study, but really having these lasting relationships with women and their families and in the community. And I think then that brings together also that people can actually see that translation into practice, right? So it's not just going to end at the publication as a journal article, but really seeing through into changing practice on your wards there. So thank you so much for sharing that. And Yoshida, just as a follow-on question, to that, the team at JNMC has done so much work to be able to better include and conduct include pregnant women in clinical trials and conduct some of these really large-scale maternal health trials. What would you see as some of the key barriers left today that we could work to address as a priority?
The key barriers for involving pregnant women again are at various levels. So at the level of the pregnant mother itself, the illiteracy and lack of knowledge about the various health problems which could occur during pregnancy, and lack of awareness of research and the clinical trials amongst the family members of the pregnant woman. Because what happens here is the family members, especially the mother-in-law and the husband, take a decision on behalf of the pregnant mother. The pregnant mother is not allowed to take any decisions on her own. So they are worried mainly, first thing is about the safety. And secondly, there are certain cultural practices in India which do act as a barrier for pregnant mothers being a part of a clinical trial. Say, for example, there is a myth that, consuming drugs, like if you're a part of a clinic, some drug trial, you consume some drugs. There is a myth that it could increase the weight of the baby, which could result in a C-section. And normally these women don't want a C-section. Similarly, there is a practice that the pregnant mothers go to the maternal house for delivery. So if there is a long-term follow-up study, maybe at 6 months and 1 year, it would be difficult for the pregnant mother to be a part of it. Similarly, even with some study procedures like repeated taking blood samples of the baby could be one of the cultural barrier. And then one most important thing here is ASHAs. Like ASHA is an interface between the public health system and the community. Now she's the one who links the pregnant mother to the healthcare system. So she is responsible for providing counseling regarding antenatal care, ensuring that she has antenatal visits, ensuring that she delivers in a hospital, she gets all the immunization. And apart from this, she has multiple responsibilities which she is answerable to the government. So these ASHAs, as I told you, they are a link between the pregnant mother and a healthcare provider. They have so much confidence because they are in repeated touch with the ASHA. So these ASHAs, because of their excessive workload, it's very difficult for us to involve them in the trial, because existing workload plus another additional workload, plus they expect an additional incentive for the extra work which is done. So that is one thing. And similarly, at the medical officer level at the periphery, especially at the primary health centers also, they have multiple national programs, around 300 to 800 per medical officer. So again, it is increased workload and lack of involvement in clinical trials. So they are also not, especially in randomized control trials. So, and even at the administrative level, whenever we do a study involving the peripheral health centers, they ask for a clearance from the higher authority. They ask for a clearance from the district authority. And when it is from the district, it is from another higher authority. So we need to take clearance from all authorities. And at the clinician level, even at a tertiary care center, say, for example, currently we are doing the ACT trial where we are giving corticosteroids for late preterm births. We have a placebo arm in that. Still, clinicians are worried because gestational diabetes is not an exclusion criteria. So they are also worried in case the woman gets a placebo, in case the baby develops the respiratory distress, who is going to take care of the expenses? So that is another issue which comes up. And even I think at the ethical level, ethical committee level, they are always worried about the safety of the baby and the mother, and the insurance covered for the adverse outcomes. So unless the insurance is covered, they don't give permission for the studies. So I think these are the various barriers which I see at different levels.
Great, thanks for that, Yoshida. So it sounds like we might have made some progress, but still quite a lot that we can have to tackle there. And I think you touched on some really important points about how we sort of can appropriately engage with women and their families about these complex decisions about bodily autonomy and decisions around consent and assent to participate in clinical research. I think that's a pretty good segue to shift gears a little bit from talking about sort of the history of gender bias and what some of the current barriers are, to who might we need to engage with to make sure that we're both safeguarding therapeutic interests of pregnant and lactating women and people, but also allowing for these innovations to occur. So Claire, a question for you. What are some of the ethical questions or considerations that arise for some of these different stakeholders that Yoshida has mentioned? So women, families, ethics committees, regulatory committees, and so on.
Yeah, thanks, Megan. And Yoshida set out the stakeholders really comprehensively. And coming from a research ethics perspective, certainly the guidelines in Australia, and I think in many other countries, are very focused in research ethics on the processes of doing ethics. Ensuring risks and benefits are weighed up, and respect for people, giving them choice and information. But I think there's a real need to have high-level principles, even at the level of guidelines, for implementing fairness and integrating fairness and equity through the whole system of research. And that includes the principle of justice and fairness for populations that research is prioritising. And that should, begin right at the top. And then that same principle can guide fairness and equity, and ensuring that all populations who need a research focus are included at the level of institutional visions and priorities for research, at the level of ethics committees reviewing what's coming in. So it would be, I think, helpful to have a set of principles about what is ethically ideal to ensure pregnant women are covered in research, and pop those same words through all of those levels of stakeholders, so that people are all sharing a similar language, and there can be enough of an impetus to sort of be consistent across countries. So I guess it's a long way of saying ethically, I think it's a high level plus an integration through the system. Yeah.
Yep. No, that's great. And it's really great to have that ethical perspective to this work as well, because it's obviously so multifaceted. We need to bring expertise across different disciplines together. And maybe just to follow up on that, Claire, in your opinion, who would hold the responsibility to address some of these critical ethical issues that you've raised?
Yeah, so I think everyone, but some people probably have more power to make a change. And the ethical questions that arise in any research is to think about risks and benefits, to think about protection of people's autonomy and privacy, to giving information, to being fair. So those questions are important for the clinician on the ground that Yoshida was mentioning too. Like, I think it's worth even starting there and asking, do they have an ethical responsibility beyond the patient in front of them to think about the population of patients that they're treating? And I don't think clinicians in general are sort of, particularly certain about the scope of their obligation in that area, and maybe it depends where they work. But often, so I think it could start even from education of clinicians to say this is actually part of your role, not just to be speaking to the person in front of you. And then I think you can get ethics committees to start taking some responsibility and saying, well, look, rather than waiting, just reading and looking for problems in this research project, do we have a role to actually shape the type of research that's going on, and do institutions have a role? And I think they do. I think you can't just bunker down into your own little sphere, because clearly that doesn't happen in many, many other areas. So I think it's being really clear about that broader responsibility at absolutely every level. Again, it's an integrated, consistent approach that seems to be required.
That's great. Thanks, Claire. And I think these sort of broad responsibilities for all of the different stakeholders is really critical. It's definitely challenging, but critical. And just to pick up on something that you mentioned about sort of whether a health worker is viewing just the woman in front of them as their responsibility, or looking at sort of this broader population as well. We identified some really interesting similarities in the systematic review that Mridula presented before as well. And also looking at how that comes down to an individual woman as well, whether she's viewing it as, am I making a decision about my body and my pregnancy? Or did I have a sister or a friend who died during childbirth, who I might feel then I have a responsibility to the broader community of women about making these decisions that might then inform whether or not to participate. So you're spot on in sort of looking at the different decision making that's happening at these different levels, and how they might be being made.
And I think you can, sorry.
No, please go ahead.
Oh, I was just going to say, it could be useful even to, so on the one hand, I'm suggesting high-level principles that are integrated, but also at each level of stakeholder, a series of questions that can prompt either reflection or response. In the treatment, people that I've seen today, is there some data I can collect that could be forwarded about the clinical picture I notice in the pregnant women that I see, so that you start making empirical evidence from the ground up about what's required. It's collected, even if it's not overly systematic, but it just means people get involved in it.
Yeah, and it's almost like it's sensitizing people about the sort of the different ways that you can sort of start off evidence collection that could potentially lead to a bigger research project or contribute to something more broadly. No, that's a great point. Just a reminder to folks who are joining us, please feel free to ask a question in the Q&A or to pop a question in the chat if you have any. I wanted to shift gears a little bit back to Anna. From your perspective in the sort of gender equity field, who would the key stakeholders be from WHO's perspective, or sort of more broadly in the women's health gender equity field about gender responsive research and development?
Well, I think Claire just said it really well in terms of this involving everyone. And I think bridging this gender evidence gap in global health is definitely a collective effort. There are many actors in the research ecosystem, and when we just focus on one of those, I think we miss the broader system in which they are operating. It's also about the process of taking the demand for taking evidence to policy. So we need to target a whole series of different actors to be able to promote better practices in research and development. And it can't be a partial effort. They all need to be singing from the same hymn sheet for there to be really effective change. And obviously my own organisation, the World Health Organization, we have a key role to play as well as the global standard and norm setter in public health. Research funding bodies are also really key. No proposal should be approved without proper consideration of these considerations. And the same applies, as we've just heard very, very clearly, to research ethics committees. Journals shouldn't be accepting for publication any research that's only really considering part of the population or even part of the questions with respect to the health of that population, really just on the basis not just of social justice, but also on the basis of that not being good science. Regulatory agencies as well should be looking for the best, most inclusive science for products and interventions. And of course, policymakers should also be demanding that evidence to make much more gender responsive health policy in the field of reproductive health, but also beyond reproductive health. And as we've just heard, I think research and academic institutions are also really key key. They need to ensure, especially all those new researchers that are coming up, that they're fully equipped with all the skills and knowledge that they need to ensure fully gender responsive research and development, that they are looking beyond, as we've just heard, just the person in front of them, but they're looking at the broader responsibilities that they had and the broader considerations. There are a lot of materials that are out there these days to strengthen that capacity. In fact, in WHO, we did review a lot of the materials that are on offer, and we're really trying to actually crowdsource more materials which are relevant to a variety of different contexts and are relevant along the research continuum as well. So it is really, in a sense, much of a matter of will, as much as a matter of gaps in information and resources. But that said, everyone needs to be insisting on the same as a matter of health equity, of a matter of gender equality, but also, like I said, just as a matter of good science. And I think that that's sometimes that we don't stress that part as much as well to everybody that's involved along the continuum. Yep.
That's great. Thank you so much, Anna. And there was a question that came in from one of the participants that I think is a nice follow-on for you. The question is, how can unconscious gender biases in research funding potentially be overcome, and sort of what would our role be to play to, I guess, potentially educate funders and donors about the importance for gender responsive funding?
Well, I think we just have to make these messages using multiple arguments. I think very often we are making them with respect to, oh, this is a nice thing to do, but this is also a really, the right thing to do, and as I said, in terms of science, in terms of effectiveness. I mean, from our own point of view with WHO, in terms of achieving health outcomes, you're not going to achieve all the health outcomes that you want to achieve unless you actually really have the best science upon which to operate, and unless you're really considering the whole of your population. So I think it's also about the arguments that we're making to different institutions to be able to show that this is a really wise investment for a number of different reasons, and make that, as Claire has been saying, make that as part of the high level considerations, but also ones that flow through all the levels of the ecosystem.
Yep, that's great. Thank you. There's another question that came in the chat that I'd like to pose to Claire and Yoshida, just to have two different opinions from the ethics side and the clinician side. The question is, are there any practical or ethical considerations for either adolescents or young first-time mothers when developing drugs to treat pregnancy-related conditions that we might need to consider? So specifically looking at adolescents or young mothers that we might have additional ethical or practical considerations.
Yeah, when we are having adolescents, adolescents and pregnant mothers for the first time, if they're very young, we need to take consideration of the family members also. We need to take a consideration of the family members also. I'm not very sure from the ethics perspective. We need to have a consent. That's it, from the participant. I don't think there's any other additional consent required for participants beyond the age of 18 years. Less than 18, we require an additional consent from the parent or a guardian.
Yeah, look, I would agree. I think that population of young mothers or even adolescent mothers is an example of greater complexity, and I use that rather than vulnerability. Of course, they are vulnerable, but sometimes when you use the term vulnerable, that often means that you take a protective only hat on, and really they just have a few extra complexities associated with ensuring they're supported when they receive information. But other than that, I think they're a sort of subset of the overall set, and they don't change the considerations and the treatment, except of course, yeah, they definitely need more support and perhaps, yeah, more guidance. But other than that, they shouldn't be excluded, I think, on that basis.
Yeah, it's an interesting point, isn't it? So the presumptive exclusion somehow isn't going to work because they might have additional complexities. And I think in the maternal health space, in particular, in certain contexts, adolescents might make up a small proportion of birth, but they tend to have the worst outcomes, especially for things like obstructed labor and so on, which is partly due to smaller bodies and so on. And what we've seen also in some of our work is that there's quite a bit of a mixed bag in terms of what our policies look like in terms of, is it, you ask for the parental consent of a 16-year-old who's at the hospital to give birth, or is she potentially considered to be an emancipated minor? So as an example, some of our work in Ghana, if she's pregnant, then she's considered an emancipated minor, sort of regardless of age, which has sort of different sorts of complexities in that, but also sort of giving that potential benefit to be able to participate in research that might impact them quite greatly as well. So I think it's that sort of critical balance to consider as well.
Yeah, yeah.
We have a question also about what we think the likelihood of pregnant women might look like to participate in research during pregnancy. So if you wouldn't mind, I would like to pose this to both Mridula and to Yoshida. So Mridula, from the perspective of the systematic review, could you talk a little bit about what we found in terms of whether women were willing to participate or not, and what might then influence some of those decisions?
Sure. Thanks for that question. So we were very fortunate in our systematic review to actually have a range of literature that looked at both motivations for participation as well as reasons why women declined. And while in the majority of instances, it wasn't in the context where a trial had to be halted or couldn't proceed because there were too many women who declined, there were still different considerations around why women chose to participate and why women didn't. And one thing that we noticed quite consistently was whether the threat of the disease progressing untreated, whether the risk of that and the implications of that were worse for the woman herself versus the risk of taking on an intervention that's an experimental one. So while broadly speaking, women did talk about having kind of a heightened perception of risk and kind of that affecting their decision to participate in a trial, it was a much more nuanced assessment based on how healthy or kind of how prone to disease they felt. Also, whether women had experienced a complication in a previous pregnancy and kind of whether they were then motivated to try and prevent or treat that complication early in a subsequent one. But also in terms of what they assumed would be some of the personal benefits around participating in research. And often that was discussed in the context of getting access to higher quality care. And so particularly in contexts where women had access to more diagnostic tests, to more doctor's visits, etc., which they otherwise wouldn't have access to in usual care, those were also often motivating factors to participate in research. But I think Dr. Yashita will give us kind of a good idea of the context in India, and particularly with her experience conducting clinical trials in Belgaum.
Yeah, regarding a pregnant woman consenting for any trial for that matter, as I already told you, they take the they need the decision of the other family members, especially the husband and the mother-in-law. And many a times what happens is, as I told you, they come to the maternal place for delivery. So husband is somewhere else. So we've had in some of the trials where we couldn't contact the husband because husband has to give a green signal for her to be a part of the study. We were not able to contact the husband. And secondly, as Mridula told, mainly they ask is the benefits to the baby. Even if there is no harm, they ask us a leading question: are there any benefits to my baby? You know, so if there is some benefit which we are offering in a trial, she will be willing to be a part of the trial. And as Mridula also said, that we give her additional care. because what happens when she comes, when we are talking to her about the trial, we are telling her about the trial, there is a rapport built between the research nurse, the research officer, the staff there. So they feel very secure, to be a part of the trial. So they give consent regarding that also. So basically, it is the rapport which they have with the care provider at any level. So that is very important for them to be a part of the trial, and there should be a commitment from the healthcare provider. So if the commit from the healthcare provider at any level, at any given point of time, also make them to consent as they maintain a very good relationship with the healthcare provider.
That's great. Thank you so much, Mridula and Yoshida. I think that's shines some really important light on how does the research actually take place when you're getting down to the level of whether it's a research midwife recruiting into the trial or engagement with the research staff, or even coming back to what is that relationship between the woman's healthcare provider and her, and that communication look like is really critical spots to move forward. So we've run out of time for our panel, but I'd like to extend a really warm thank you to Claire, to Anna, Yoshida, and also Mridula for jumping in for that question as well. I think we had a really excellent discussion and really benefited from having your very multidisciplinary perspectives on this. So thank you so much for that. And I see rounds of applause coming in from the audience. So yes, thank you very much as well. I just wanted to say a few bits to round up this part of the webinar. So I think, as we can tell from the comments from the panelists and from the presentation, we have a substantial unfinished agenda to improve the participation of pregnant women in biomedical research. And there's a lot of different actions that we can potentially take in research and development and innovation and in the global health communities more broadly to act today to start to eliminate some of these harmful gender biases that are plaguing maternal health and biomedical research more broadly. Some of the goals that we set for ourselves and for this community more broadly would be across these 5 key domains. So the first is to grow reciprocal partnerships that are between research and regulatory stakeholders, and this can help us to better engage with what are some of the most pressing issues in research and development, and how do we make sure that they can be translated into practice. Second, to make sure that we're prioritizing multidisciplinary research about safe participation of pregnant women across all stages of biomedical research, and rather from coming from this sort of afterthought after a drug has been taken to market or a vaccine has been developed, and then thinking about pregnant and lactating women down the line, engaging from the beginning across all stages of biomedical research. Third, we'd call for the continued raising awareness of stakeholders on the value and ethical imperative of different pharmaceutical innovations in maternal health. So of course, this webinar is a starting point for us, and we'll be working more actively in this space with these different groups of stakeholders that we've discussed today about what some of these wicked issues are. Fourth, and I think this ties up nicely with some of the comments from Claire about working to reorient ethics committees to improve focus on responsible inclusion of pregnant and lactating women, rather than having the presumptive exclusion for the reason that they are pregnant. So I think that this is a really important area. We can do some practical work in all of our institutions that have ethics committees. And then lastly, we can work together to conduct regulatory analyses that can help to assess the bottlenecks that prevent equitable inclusion of pregnant women in biomedical research. And this can help us to then unpack what are the different sort of levels and areas where we might intervene to have a positive change to improve how pregnant women are included in biomedical research. So thank you so much. That's it for me, and handing back over to Metin.
Thank you, Megan, and thank you to the panelists for this wonderful session, wonderful 60 minutes or so, where we could really interrogate the important challenges. There have been a number of very challenging questions in the chat as well, and I think we will try to address them when we send out the video, but there are clearly important issues. One message that I think comes across to me also taking into account our previous webinar where we were talking to some of the colleagues from the US, where there has been a lot of progress in this field, is the power of advocacy. And I think we need to instill a culture of research and evaluation during pregnancy, and that has to filter through to not only clinical care providers, but also women and families, that they may or may not benefit themselves, but there's clearly societal benefits that are hugely important for that community and for the broader community at large. So, and we have been working with colleagues in the product development partnerships in Geneva area. As you know, there are a number of organizations working on trying to develop new drugs for malaria and neglected diseases. And our partners at Medicines for Malaria Venture lead an PDP advocacy group in Geneva area, trying to address these things from a biomedical perspective, as Megan was suggesting, but also to sort of make this an integrated plan of inquiry, that it cannot be one isolated research project to look at challenges and then go on with a randomized trial without addressing these issues. So I think we need to bring the gender issues, the challenges around inclusivity at a point where these research projects are conducted. And I think the systematic review eloquently presented by Mridula is going to inform our future priorities in this field as well. So thank you very much to everyone, and thank you so much to Megan as well for excellent moderation. Please keep this space. We will continue to communicate with you with new interesting topics in this space to accelerate innovation for mothers. Thank you very much for your contributions. Bye-bye.